Welcome to Boston University's Occupational Therapy webinar series hosted by Pi Theta Epsilon. We are so glad you could join us. This webinar series is designed to discuss new and emerging practice areas in the field of occupational therapy. This is the second of 4 webinars that will be held this semester. Our next webinar will be held on March 27th and will be focused on sensory-enhanced yoga. Today's webinars will be presented by Karen Duddy on the topic of primary care, followed by Sam Monahan speaking on the practice area of neonatal intensive care unit. For our audience, please type in your questions throughout the presentations via the panel on the right-hand side of your screen, and please indicate to whom your questions are directed. We will have a few minutes at the end of Karen's presentation for questions, and again at the end of Sam's. Our first presenter, Karen Duddy, currently works as the supervisor of the OT department at the VA in Long Beach, where she works to integrate OT as a part of an interdisciplinary team in general primary care, as well as for care teams in women's health and mental health. We now welcome Karen to begin her presentation.
Thank you very much. I'm quite happy to be here. This is exciting. Let's see, I'm here to talk about occupational therapy in primary care. And so I wanted to share a little bit about how it has developed here at the Long Beach VA and maybe tell you just a teeny bit about the VA itself. And we have approximately 1,400 OTs and CODAs working in about 170 medical centers and clinics throughout the nation. So here at the Long Beach VA, we have 18 OTs, 5 of whom work in the spinal cord injury healthcare group, and it's separate from my group. And the remaining OTs work here in, let's see, we have acute care, skilled nursing and rehab, general outpatient, hand therapy, mental health, substance abuse, chronic pain, and primary care, which is what we are here to talk about today. So I'd like to share with you a little about the process through which we have joined forces with primary care and the things that were considered when deciding the referral mechanisms and which areas to focus on. Also, I think it's helpful to know how we evolved over time. We had many lessons learned, and there were lessons forgotten that have to be relearned again. But we'll start by briefly illustrating the VA primary care model. So I think everybody by now knows about patient-centered medical homes or primary care medical homes, and it's abbreviated as PCMH. So the Veterans Health Administration, or the VA, it's the largest integrated healthcare system in the nation, and it began implementing its version of the PCMH model throughout all the VA primary care clinics in about 2010. And so the PCMH model has been around for some time and has really, was integrated starting about 2008. And even with the ACA changes happening there, it's not going away. So, this whole team-based care is here with us to stay. So the VA's model is called the Patient Aligned Care Team, or PACT. And you can see in the bubbles that who the regular team members are, and it's a physician along with nursing and support personnel. And this model was intended to fully transform the VA healthcare system into a patient-centered care model. While I think that we've made tremendous progress in implementation of this model and really focusing on the needs of the people that we serve, that our care processes still resemble kind of a regular medical model or a disease-focused model. So in as much as we're looking at the whole person and trying to respond to what their needs are, we still have this, and every other primary care model still has this kind of 15 or 20 minute increment appointments. And the doctors, regardless of what they want to do, are still sometimes limited in what they're capable of doing. And so, these models may not look very new. But I think that OT would fit nicely with the comprehensive person-centered mission of the PCMH models. And this is why I went about trying to introduce the OT bubble into the PACT model. So I think pretty much I could describe us as being PACT adjacent, simply because we aren't cohabitating. But they do think of us as part of the team, which is a very good start. So currently, if you can see, the only rehab profession directly involved with primary care here is OT. And so we establish a direct relationship with them, which is a unique part. So PT, they have to go through other ways to get to physical therapy, but we are part of PACT. So one of the things, first we need to understand what OT in primary care is. We've read a number of articles about OT in primary care, and we know we want to be there, but there are variations in practice patterns among OTs in primary care. So it helps to conceptualize a little bit. So if you look at the first question, primary care OT, when you think about primary care OT, you think of like hand therapy or mental health OT or phys dis OT, and it seems something like a separate specialty area in and of itself. And so, I was thinking that didn't quite fit. So I thought, okay, well, OT in primary care, that still identifies as we're occupational therapists and we bring our OT therapy selves into this type of setting. And that, I'd say that fits a little bit better, but still, what does that look like? We know that it's a little bit different. So first question is it a place? Are we doing primary care only if we are in a primary care building or office? I mean, what if I'm seeing someone in the primary care clinic who has a hand injury, let's say? Is it still primary care because I'm in a primary care clinic, even though I'm doing something kind of rehab-like? So, you see, I need to know for a few reasons. One of which is to understand the types of services that I'll be providing it to whom. So that's why it's important to kind of recognize what the idea is behind primary care and what do we do and how do we fit. I mean, another reason is that so I can explain to other people what primary care OT is, which I've actually gotten a lot of questions on. So that is why I'm on this mission to kind of understand or conceptualize OT in primary care. So let's continue with that. Well, is it a set of principles? These principles are what initially drove me to want to be a part of primary care. I like these principles. These themes speak to me. So the idea of team-based person and family-centered care, that concerns itself with treating the person across their lifespan, to me, that's very OT. Primary care as an entity, to be of high value, should be accessible to people when they need it, not just in urgent situations or, every 6 months or so. In this way, they can stay as healthy as possible, which is also part of that high value factor. So the other aspect of high value is that through this person-centered, coordinated, timely, team-based approach, the overall health of individuals is expected to increase, and the use of high-cost services should decline. So OT fits with this idea, right? Helping people to optimize health through engagement and meaningful occupations. I mean, that's what I see as a way that OT contributes to that mission. But, it may not be, primary care may not be just about a set of principles. So in this illustration, this is looking at it as, in a way, like a funding structure. So primary care as being just an aspect of healthcare that is funded separately. So this illustration, it really shows the whole model. But if you look at the foundation here, there is a payment element, and that makes sense. So it's common for PCMHs, or the larger healthcare organizations. In that context, the larger organizations provide both hospital care and ambulatory care. And that would be like Kaiser or the VA. So it makes sense that they receive overall funding based on the number of people they serve and the expected costs of providing that type of care, whether it be just ambulatory or hospitalization as well. So what they're trying to do is by saying, if you focus on comprehensive care in this whole person across their lifespan, you should be able to do some prevention and planning and coordination and save money. And that is the whole idea of a coordinated primary care approach, keeping people healthier and out of the hospital. So in those models, OT, if you think about it, if it's one source funding, OT can be hired as a salary employee, let's say, where OT can provide wellness services, for example, or any other combination of things. So I think it's important that we understand the funding and how funding presently and maybe in the future so that we can find out how we can best contribute to the mission of these organizations. And I think that we are uniquely positioned to do so. We're just not used to, selling ourselves, pitching in that way, having this set of services that we go and say, we can contribute greatly to your mission and the people that you serve. So eventually it makes sense to me that understanding primary care is about context. So this is how I went about kind of engaging myself with primary care. So first I developed somewhat of a business plan, which I think is a very important step. And I looked at the performance data and satisfaction reports about primary care. And so I felt that we could address patients' daily living concerns, the problems that they experience because of their health. So this makes sense because when patients sit down with their primary care providers, they often start by saying, well, I'm having a hard time doing, whatever it is, getting up at night and going to the bathroom, let's say, or having a hard time golfing because my back and my hands hurt, or my balance is a little off. Or I'm in so much pain now that I can't, what have you. And so the common theme with these statements that come from the patients or clients is that what bothers them is how those aspects of their health interfere with what they want to do in their daily life. And that is the thing that I hear, but that's not necessarily what the physician hears. What they hear has something to do with a disease or a diagnosis that the physician is now going to treat. So for me, it's about how illness interferes with patients' lives. So doctors deal with illness, OT deals with lives. And to me, that sounds like a perfect partnership, because the doctor speaks their own language with the medical thing, and patients want to talk about their lives and what they're having difficulty doing, and doctors really can't. They don't have the capacity to listen to that, but that's where we thrive. So that's kind of how I focused. So then I had to set about to describe that focus to physicians. And I tried to come up with a few general statements about what we do. Anyway, so the issue is, how to explain or to sell it in terms that another entity like a provider or an administrator would understand. So I was working on these 3 bullet points, and of course they made a lot of sense to me because they're very OTE. And in truth, they're kind of too OTE. I'm using our language that makes sense to me, and it sounds great, but it's kind of, it really doesn't resonate with anybody else. So here I am talking to the chief of primary care. He says, okay, let's see. Will you fill out disability forms, he says. No. Well, so what do you do? I say, let's see, send us people who are having difficulty taking care of themselves for whatever reason. Can you help them take their medication right? Yeah, I can do that. What about hand pain? Sure. Yeah, that I can handle that. So finally, they were starting to throw out things that were interesting to them, things where they thought they needed help, things that were painful, like the disability forms. And unfortunately, we can't do that for them. And so that helped, finding out what concerns people had and what the difficulties they had with certain populations. That made all the difference in the world. And then people started sending us those folks that they thought we could spend more time with. And so then the next question is, well, how do we send them to you? How do we consult them? In the VA system, we have what's called a consult. And it's part of the electronic medical record. And so what people do is they enter in this consult, and it goes directly to our department. So the significance of this is, number one, you have to create a way for patients to get to you. That's the most important part. This one, though, is in each section of each healthcare group or section of the hospital has its own consultation area. So I decided to put occupational therapy right in primary care. What that meant symbolically is that primary care has its own OT. And they really liked that because, as you can see, there's not physical therapy or anything else there. they really loved having their own OT. And so that's great. And if you can see down below where it says primary care behavioral health, we also participate in some of these classes with psychology and nursing. And so that's been really fun. And we have one OT who does a Tai Chi group too, which is really great. So over here this is me and Tom. And so we were at a primary care picnic. And, you know, it's important to kind of hang out and get to know everybody. And of course, like OTs, we ran to the grill and started cooking. So we had a very good time. Tom's been here at this VA about 30 years. I've been here about 15, so people know us pretty well, and that really helps. They already knew who we were and what kind of people we were, and they had an idea about how we could, you know, contribute as part of the team. So that helps. So this is the first part of the consult. They click there. And then I decided to make a little template that says, here's what we do. And they could check on any of these items and write in what they wanted. And so that's pretty much what they do. They end up checking on everything and then writing up what they're referring the person for. That's fine, as long as they get to me. So a template kind of helps. Note that after a while, when you have writing, they ignore it. They don't read it anymore. They just want to jot down a little something. So always give them space. Okay, so now that we've been partnering with primary care for a while, what we started out with, or our idea about, it's changed. It's changed a little bit. So let's look at our original messaging. So if you can remember those 3 bullet points, the re-engaged and valued roles, you know, the very OTE statements, that's where we started. And you can see the volume of consultations that we've had over time. So these are completed consults, and you can imagine something that I stopped doing around, you know, in 2006, between 2016 and 17 was marketing. So I did not feed and water the service, and you can see the result of that. So let's see. So those are the numbers, and here is what they sent people for. So I went through and looked at all the consults for the last year and kind of categorized them into types of services. Hand pain, of course, you know, that's on the top of it. You know, I guess I understand why they send them to OT. So fortunately, you know, I was doing hand therapy before supervisor, so I could help out a lot there. A lot of ADL equipment. That was another big one. They have to come through therapy to get equipment. Another big section is, are they safe at home? So there's a lot of worries about dementia, about balance, about just not thriving, or, you know, inability to really manage their IADLs. And so people were at risk for not being able to maintain out in the community. And so that's a big one. Chronic pain is also a huge issue. It's the 5th top 5 reasons, you know, that people go into the emergency or primary care. One of them is chronic pain. That's usually number 5. Medication compliance has been a big one that's been rising. We've become pretty popular for that. You know, trying to understand how people can take their medications on a regular basis. We have a great adaptive cycling program that is probably more unusual. It probably doesn't happen outside of the VA. So we get a lot of people who have spinal cord injuries, amputees, you know, just other issues out on recumbent bikes and different cycles. We're doing a lot more of the wellness stuff, so health behaviors and coping. We've really expanded there, so that's been fun. And this is a little graphic about where these consults have been coming from. So this is the breakdown. The other category includes things like vascular, for stocking donors, and how to manage lower extremity edema, from pharmacy for the medications. HUD-VASH, which is it's a partnership with Housing and Urban Development and our VA supported housing program. So it's vouchers for housing, and we go in and try and make sure that people are appropriate for the level of housing that they have, and see if there's any needs that they have for remaining independent in their apartment. And Neuro sends us some things too. And we're doing some more telehealth through Neuro, so that's fun. But let's focus on the green and yellow categories. The green one is the caregiver support program, and that's something that I started working with the caregiver support program, and that's unique to the VA. But the great thing about that is that the message is that we can identify a place that really needs our help. And, I just introduced myself, and you can see how it went, how it took off. So we got a lot of, referrals there. And so we're doing pretty good. And the women's mental health and women's health was started by one of our therapists, Allie, and she created this program, has been working closely with them, and that's taken off. And let's see, so this is just a conceptual model I put together to try and understand our scope and what type of approaches and what do we need to know. So essentially, our interventions are aligned with primary, secondary, and tertiary prevention approaches. So we provide a wide range of things for our veterans, but we think of it primarily in that prevention category. There are challenges. Number one thing you have to figure out is funding, how they can afford you, so to speak, and how you can find your way into seeing patients. And you have to know that it's not productive at the beginning. So just understanding the culture and the flow and finding your fit is a really good place to start. And certainly having confidence and initiative and working well with others. So just get OT there and they will love us. And the thing is you have to keep promoting it. So focusing on the customer, it's your business, grow it, and trust your skills, know what you don't know, and always look for what is the value in the services that you provide. The last thing I want to have you think about is, what will it become? So we talked about what it is. What will it become? And we know that new healthcare models are going to pop up, but this is a private one with Warren Buffett and Jeff Bezos of Amazon and Jamie Dimon from the bank, from JP Morgan Chase. And so they want to start their own healthcare system for their employees and families. Just think about that. I think that is a wonderful opportunity. So they say that as hard as it might be, reducing healthcare's burden on the economy while improving outcomes for employees and families will be worth the effort. And this is what they see is going to lead to success. So success is going to require talented experts, a beginner's mind, and a long-term orientation. A beginner's mind, it's knowing that we can make a difference for the future, seeing opportunity that could be instead of what was. And a long-term orientation is looking at the overall long-term health and wellness of people and their families in the context of their lives. So I think this is a great message for us. I think we are talented and we have great vision and we look at people as a whole throughout their lives. So I hope that we pay attention to the future, and I shop enough at Amazon. So I care about their workers and I wouldn't mind working there. I'm just saying. But so I think that that's a great opportunity for us. We would fit. And that is where I'd like to leave that. I'm in the purple. Gabriel Messenger is an OT who works in chronic pain and primary care. Allie Ross, she designed the women's program. And the two kind of flocking me were in height order unintentionally. There's Tom, who works in primary care, and Doreen also, who works in primary care. And we were at the AOT conference in that picture. And that is all that I have for you today. And so I could do some questions here.
Thank you, Karen. That was a great presentation on OT and primary care. We do have a few questions from some of our viewers. Okay. The first one is from Madeline from the University of Pittsburgh, who would like to know, does the VA Long Beach promote OT services for driving and community mobility, as well as palliative care and end-of-life care?
Yes. So there are driver's training programs within the various facilities. So there are hubs, like we have one here in Long Beach. And interestingly, kinesiotherapy is the one who runs it here in Long Beach. And their kinesiotherapy is it's a profession kind of just in the VA system. But typically it's run by OT in the other areas. So we have our own cars and that whole thing, our own training gosh, what are those things like we used when we were learning how to drive? So we have all the equipment, and we can invest in lifts and adapted vehicles and everything. So driving and community mobility, those are two, can be the same but separate things. So we do the whole thing. So we can provide care out in the community, teach people how to use buses, different kinds of transportation. And yes, we do have palliative and end of life care. We certainly do. And we treat people in the palliative care program, both on inpatient and in their homes, and if they come in for outpatient as well.
Great, thank you. Our next question is, do you have any advice about how to sell OT or advocate for its inclusion in primary care practices where it is not already role?
I think that is probably the most important question, and the one I get most often. And that first piece of it is know the business before. Imagine yourself as a business owner. You wouldn't just run in and try and sell yourself without knowing anything about that business or the partnership that you could have. So that funding piece is really important. You need to know whether it's even possible, whether they have the capacity to bring you in and under what terms. So that is the first thing. And knowing those pain points, or where those programs are not suffering is not the right word, but where they could really use your help. I find that when people, and this is a strange way to do it, but when people are frustrated or annoyed, it's not because they don't care, it's because they don't have the time or capacity to really take care of patients in the way that the patients want to be taken care of. When we come in and we say, oh, come on over here, we'll come talk to you, let's see what we can do, everyone is relieved. So being able to identify just a few areas that are of interest to whoever you're talking to is critical. I've made mistakes of going, hey, we could do OT for all, whatever you want, we could do. And people, they don't know what to do with us when we say that. So that's why the research about your primary care office and how they run and what they need, research about that is vital, because you can target your message and say, we can do this, this, and this, and just keep to 2 or 3 things at the beginning, because they will stop listening to you if you keep on talking. So target your message and understand the finances. Find every way possible so that they have nothing to say no to.
Thank you. That was a great response. We have time for about one more question. This is from Michelle. What advice can you give a new grad to pursue a career as an OT in primary care? What skills and/or experience are the most important to gain before seeking a career in primary care?
Yeah, I think that, and you probably are aware of this, but I think that that's a controversy in our own field, is that do you have to have a lot of experience before you can be effective in primary care? Some people say absolutely, and you could see from the list of things that we were attending to, that we needed to have a broad base. But that's also because I let people send us what they wanted to send us, and then we responded. So depending on where you work, if you shaped what your skill set is and said, here are the things that we're going to focus on initially just to get in the door, you want to be very good at those things. And keep in mind that this isn't rehab or the medical model per se. It is helping people engage in their lives and do the things that they want to do. So a lot of that you need to have some creativity, you need to be able to listen, and you need to be able to connect with patients. That connection with patients is the thing that they miss when they go see their doctor. They want their doctor to spend more time. But if we are listening and we are helping and we are problem solving with them, that I find has been the key, and what patients go back to their doctor and talk about how wonderful we were. So new grads, yes. However, you do need to be aware of diagnoses and how those conditions affect people. But listening and helping people problem solve within the context of their life, not just telling them what to do, Those are the main skills. If you don't have that, I don't care how many years of experience you have, you won't be successful.
Great. Thank you again for speaking about OT and primary care. And if we have time again at the very end of Sam's presentation, we may be able to ask some more questions about your presentation.
Sure.
Thank you, Karen. Our next presenter, Sam Monahan, has been working in the neonatal intensive care unit as an OT for the past 5 years. Her roles include working with newborns and their families to maximize the child's participation in essential daily occupations, such as feeding, growth, and sleep. We now welcome Sam to begin her presentation.
All right. Hi, everybody. I'm Sam. I'm so excited to be here. I'm going to talk to you a bit about OT's role in the NICU. There's a lot of information, and I know we only have a short amount of time, so I'm going to try to get through as much as I can without talking a million miles a minute, but I am a fast talker, so I apologize ahead of time. So just a little bit about myself and the plan. I'm going to introduce sort of OT's role in the NICU, talk about the NICU environment, discuss the types of OT assessments and evaluation we do, the types of OT intervention you might see, and then leave some time at the end for questions. I did go to BU and I graduated, finished the classroom work in May of 2011. And then I did my field work and I officially graduated in January of 2012. I've worked at St. Elizabeth's in Brighton, just outside of Boston or part of Boston, since shortly thereafter in April of 2012. And as part of my job there, I do split my time between adult acute care and then NICU. So I wish I could spend all of my time in the NICU, but the size of it and just the needs of the job don't really facilitate that. We do have a level 3 NICU, so it is the most acute within our Steward network, hospital network. But that being said, level 3 is the highest acuity NICU. But in Boston, we have several other hospitals that have also considered level 3s, but they have like MGH Children's, the Brigham. They have NICUs that are able to do different surgical procedures and higher level things that we don't really cover at St. Elizabeth. So occasionally we will transfer babies out if needed for something more serious that we just can't address at our NICU. So talking about OT's role, I mentioned evaluation. We obviously do an evaluation on every baby, just like you would a normal any OT setting. We consult with nurses on a daily basis. We provide family education and advocate for the family and the baby. We provide positioning recommendations and consult with the nurses on that. We try to maximize the environment to make it as beneficial for each individual baby. We assess and intervene for head shape, feeding problems, neuromuscular development, and then the bottom line, just like any other OT occupation or OT job, we maximize the occupations of the NICU client. So talking about, before we can really delve into OT's role in the NICU, I kind of want you all to see what a NICU environment might look like and how that might impact our client. So looking at these pictures, you can see how kind of busy and overwhelming the environment is. You can see different isolettes and pods where the babies are. There's lots of staff, tons of equipment. I'm sure you can imagine how loud and chaotic the environment is. It's bright, there's beeping. It can be really a challenge to address the things we need to in an environment like this. So what does it look like a little bit further? There's tons of equipment that I mentioned. There's respiratory machines. There's the different types of isolettes and cribs that the babies use. There's breast pumps, bottles, pacifiers. There's different phototherapy treatment lights. There's the equipment that the babies use within their isolettes, like Snuggle Ups and Freddy the Frogs, which I'll show you later in the presentation. There's the ventilators. There can be various types of cribs, including like large full-size baby cribs if need be that we bring in from an outside vendor. There's obviously the medications. There's the staff, family, visitors, might have consultation with social worker, lactation consultants. There's a secretary, PT, OT, and speech, depending on what NICU you work in and what is available. There's a dietitian, so kind of an always revolving door of people in and out of the NICU. You can imagine it's noisy. There's a lot of commotion, chaos kind of going on. It's really bright. There's tons of lights, both necessary for procedures, but also at least in our NICU, there's nice big windows, which sounds lovely, but for our babies, that's not necessarily the most appropriate setting. It can also be extremely loud when there's a new delivery, a new baby coming in. I wanted to mention there's obviously every baby is monitored and they're on the respiratory and heart monitors. But as a result of that, they're sort of constantly always this underlying beeping. And there's, of course, a such thing as alarm fatigue, which many of you may have heard of, where since the alarms are always going off, nurses don't always necessarily notice. They sort of become immune to it. And that I feel like happens a lot with noise. I call it noise fatigue, where the nurses sort of forget that they're supposed to be quiet and that it's supposed to be a really calming environment. And they just kind of gradually over time get louder and louder. So that can also be a challenge and something that we address as OTs in the NICU. Some of the equipment I mentioned, this isolate is a giraffe. There's different types. That's just sort of the brand name of it. And that's where some of the micro preemies stay. The open warmer on the bottom is generally where the babies are when they're first admitted. Gives a little bit more access for the initial admission. Up at the top right corner is the bubble CPAP. That's sort of the respiratory support we provide. Generally, our babies at our NICU are not intubated if we can help it. And they are on the CPAP if that is at all appropriate for them. Some more things, pacifiers, I'm sure you've all seen. A ventilator at the bottom, that's sort of the machine that the ventilator runs off of. The top right is a traditional feeding pump that you might see. And on the bottom is Billy lights for phototherapy if babies are jaundice. So all of these things are sort of right at the bedside, taking up space, adding to the chaos. So you've seen what a typical NICU environment is. What might a realistic, ideal NICU environment, an ideal, not maybe realistic environment look like? So in order to talk about that, we need to talk a little bit more about who our client is. So obviously the baby is our client. So that might include preemies, which counts for any baby born prior to 37 weeks gestation. It might be a full-term or preemie newborn who requires special medical care. And then the other sort of subset of babies that we see are neonatal abstinence syndrome, which are babies who are withdrawing from medications for a variety of reasons. So those babies are typically full-term, but they have a very different set of needs compared to the preemies that we see. So, of course, in addition to the babies, the family. So the family is a huge part of our clientele. So we obviously want to meet the needs of our babies, but also incorporate the family, and that can be a challenge as well. So we know who the clients are, what are their needs. So the infant or preemie, you want to think of the 5 senses and you want to try to mimic the womb the best you can. So thinking about the womb, you want to think that it's dark, it provides a lot of pressure, deep pressure and tight space. It's warm, it's humid, it's really quiet. Any noises that they hear are very muffled. You want to try to mimic that the best we can in the NICU. In addition to the family, what are their needs? They want to provide attachment and bonding opportunities between the family and the baby, allow them to take part in caring for the baby, taking the temperature, providing a bath, doing the diaper changes, feeding them, of course, providing skin-to-skin care, which is good for any baby of any age. And then a little bit different for the babies with neonatal abstinence syndrome. Sometimes they don't like to be confined as much as preemies, or they are sort of sensory seeking rather than sensory avoiding. So thinking about the needs of each of our clients and how can we provide this in an environment that's already so limited. So what are the occupations of these babies? So and their families? Surviving, obviously, providing the opportunity for physiological stability. They need to sleep. Preemies generally sleep the entire day, which is what they essentially should be doing. Procuring is a term that talks about their baby's ability to communicate the needs to their caregivers. So they do this through their behavior and through signs of stress or disorganization, and then also signs of stress of organization and calmness. And so that's part of our role as an OT, is to assess these signs that they're providing and identifying when they're ready to engage with the environment and when they're ready to really participate. We want the occupations of babies, of course, feeding. They need to be able to eat on their own, and then interacting and bonding with their families. So how can we as OTs in the NICU facilitate these occupations for our client? So we're going to go back to the question of what an ideal NICU environment looks like now that we've identified who our client is and what their needs are, what their occupations are. So We want it to be dark and as quiet as we can, provide these nesting sort of nice, tight, secure spaces that provide strong boundaries, might provide deep pressure, proprioceptive touch. We can use different positional aids to provide that. We want to promote physiological flexion or a fetal position, keeping their hands in midline, providing warmth, humidity. This is really difficult to achieve, kind of the things I've mentioned before, because of the environment that we're given. So we want providing this sort of ideal environment. It allows these babies to engage in the occupations that they need to. We want to minimize distractions, decrease as much stimulation as we can. And it is really difficult, of course, like any other setting, to meet the needs of so many different clients and so many different individual people in an environment that's pretty limiting. So what an OT assessment might look like. So we assess the stress signals. Does the baby appear organized or disorganized? And I'll talk about what that might look like. And then also, how's their ability to self-regulate? So are they making any attempts to regulate themselves, or do they need maximum support to sort of bring themselves together and provide and kind of calm themselves down? How do they transition from sleep to wake? Are they coping with handling and hands-on care? Are they coping with what they need to do, diaper changes and taking their temperature, blood pressures, things like that? What does their neuromuscular development look like? How's their tone, their range of motion? Are identifying any positional deformities, which sounds more severe than it really is. A lot of times babies are born with sort of different, their ankles are twisted in different ways just based solely on how they were positioned in utero, and that kind of persists a little bit after they're born, or same thing, how they're positioned in their isolette. And that might cause kind of different changes that we need to address. What does their head shape look like? And that can be very variable depending on if they're on CPAP and the tubing that they need and how that can impact the shape of their head, as well as their feeding ability. So depending on their age, all of these things are going to look very different. So we're going to expect hypotonia in a baby that's premature versus hypertonia in a baby who's withdrawing from medications. So you need to understand what's age appropriate and what's appropriate for the client that you're with, and what you expect to see, and then is that sort of following the normal pattern. Also with head shape, it's very normal to, and I'll show you some, I have a picture coming up. The head shape is very malleable, which is normal for delivery. So obviously to ease the delivery with a baby, that's part of the reason, and then also for the rapid growth that a baby's head has in the first year or two of life. But because of that, simple things like the CPAP tubing, or like the position of their crib and which way they're looking frequently, can dramatically alter the shape of their head. So that's something that we just like to keep an eye on and sort of address early on if possible, if we can kind of prevent any of those problems. So some of the stress signals I talked about, signs that the baby is disorganized or avoiding interaction. You might see a finger splay where all the fingers are stretched out, kind of like they're saying, stop, don't come any closer. Arching of their back or of their neck. Saluting and sitting on air. I have a picture coming up where their limbs are sort of outstretched in front of them. Those are some of the more obvious signs, but some of the less obvious are even sneezing, hiccuping, yawning, spitting up, things that babies might do anyway. So it's hard to sometimes tell, is this a stress response or is this just typical baby behavior? Irritability and crying is certainly a sign, but that's often not what you see in the micro preemies and the preemies. They may not be crying, but they might be showing a lot of some of these other signs. Obviously, the other thing you want to keep an eye out for is physiological changes. So an increase or a decrease in heart rate or respiratory rate. Did their oxygen saturation drop dramatically when you're handling them? Can they tolerate even just the most basic position changes, or is it just too much for them at this time? Some pictures of some of the things I mentioned. So up at the top is a good demonstration, both the top two pictures of both finger splay and saluting, the arms sort of outstretched in front of them. Down the bottom is the picture of arching and generalized hypotonia, so where the baby is sort of flaccid. You want to be thinking more, the baby should be trying to be in a fetal position. So their legs should be tucked up into closer to their body. Their arms should be at midline or near their face. So this sort of behavior where they're just kind of flat, laid out on either side, they're sort of shut down. They're not really making any effort to self-regulate. And then at the top is a diagram of what sitting on air might look like. So the baby's legs are sort of stretched out and extended, where you're really looking for more flexion patterns, where their limbs are sort of closer tucked into their body. So signs on the opposite, signs of organized behavior that you might see are calm, relaxed demeanor. They might be bracing their legs against the nest that you've provided, kind of exploring their boundaries, making sure they sort of secure on all sides with both their legs and their arms. Like I've mentioned many times, their hands sort of at midline or near their body, like the picture of that baby on the bottom. They might be making some nice eye contact, but without sort of a fixed gaze, just sort of very natural eye contact. They can have non-nutritive suck, where they're using a pacifier and they're able to use that appropriately. And then again, the fetal position, like I mentioned. So we're looking at these signs and we're trying to assess, are they ready to engage? Are they ready to interact with the environment more? And what signs are they giving us? So if we're seeing some of these signs of disorganized behavior, how can we help them be organized so that they can appropriately feed, so that they can appropriately engage with their mother or their father, so that they can sleep appropriately between feedings and really get the most restorative sleep that they need. So how can we facilitate that? And then the other thing I just wanted to mention is that, of course, these signs are going to change dramatically as the baby gets older, but also a lot of times we have these micro preemies. They're born at 23, 24 weeks. So by the time that they're 34 weeks, 35 weeks in our NICU, the nurses are thinking, oh my gosh, this baby is 12 weeks old. They've been here for 3 months. They're so old. I'll hear a lot. This baby is so old. And they'll be encouraging us as OTs to say, can you get them a bouncy seat? Can you get them some picture cards? Can we get something for them to do, a mobile, so that they can engage? But my response to them is, this baby's still only 34 weeks. So if they're born at 23 weeks, 34, 35 weeks, and they're 12 weeks old, they're still supposed to be in the womb for another 5, 6 weeks. So really, are they ready to engage in that type of activity? So thinking about what's appropriate for their gestational age and educating the nurses and reminding them, like, you have to remember this baby is still pretty premature and they're really not ready to engage in that kind of activity at this time. So once we finish our assessment, we're of course going to create an intervention plan, and that's always talking, consulting with the nurses. It's a very transdisciplinary, interdisciplinary team in the NICU. So we provide our recommendations. We might post kind of a sign at the bedside or talk to the nurses about what we're suggesting, and then we're hoping that they're carrying it over between cares. So we're really only seeing these babies a couple of times a week. We're not there at every feeding. We're not there all day long to be able to reinforce these things. So we're hoping the nurses can carry out our treatment plan for us a little bit. We're providing family education and advocating for them, helping them to bond with their baby as much as we can, educating them on appropriate handling techniques and what these signs of stress mean to them and how they can identify them in their baby. Again, talking about positioning, head shape, feeding, how can we intervene, what can we do to help, and how can the nurses sort of carry out our plan. So the other thing we might do is if a baby is having some type of procedure at the bedside, even just a heel stick for a blood draw, or replacing their nasogastric tube for tube feedings. If I'm present in the NICU, I really do try to be present for those types of things so I can provide some nice deep pressure or provide the pacifier and kind of assist the baby to bring their limbs into the midline and really calm them down as much as we can during these maybe not so pleasant procedures. And that's another role that we can play in the NICU. I just have some pictures about some of the things I touched on. So this is kangaroo or skin-to-skin care, which is really beneficial for babies of all ages. They really encourage this even with full-term newborns. But also, how can we facilitate this for the family? So how can we encourage these micro preemies that might be ventilated or on CPAP? It might be really fragile, and nurses sometimes don't feel comfortable having them come out of the isolette and spend one-on-one time with the family. But it really has shown, research has shown how beneficial it is for the babies, regulating their temperature, regulating their respiratory rate, bonding with the parents. So how can we facilitate this? And this is really something that we have to advocate for through the nurses. We generally need the nurses and or respiratory therapists there to help us appropriately transfer the baby out of the isolette and to the parents, just to make sure all the tubing and lines are kind of taken care of. But working together with the team to make sure we can achieve this. And a little bit more about the head shape. This one on the left, the dolichocephaly, that's sort of an elongation of the head, and that can happen a lot because of the CPAP tubing. The tubes run right along their temples and to the back, so it creates that sort of elongated pattern. On the bottom right, that you can see some of the molding, we call it, where it's sort of almost like tapered in at the temples, and that's the same thing that CPAP tubing runs exactly right there. So you get sort of this almost mushroom kind of shape. And then at the top is plagiocephaly, which is kind of a lopsided head shape. And that can happen very quickly in the NICU, especially because the babies are typically positioned in the crib in the same position all the time when they're in the NICU. And because of that, the babies tend to look outward towards the environment, and that generally tends to be all in the same direction all the time. So they tend to kind of get this side preference. And as a result, they get this sort of misshapen head, and they can also get a torticollis, which is a tightening of the neck muscles on one side, which is a little bit more severe because that really causes a kind of a limitation in the muscles themselves, and that really requires more stretching and treatment. But if we can address this ahead of time, we can avoid helmets and that they might need in the future. So we try to address this as much as we can in the NICU with different positioning techniques and any type of gel pillow or off pressure relief that we can provide. And then positioning, I'm just kind of get through this as quickly as I can so I don't run too much over. Prone is considered the most beneficial. It allows babies to be a little bit physiologically more stable. They exhibit fewer signs of stress, and it really is a mechanical advantage for breathing. We try to provide side lying as often as possible and provide sort of a trunk roll for them to sort of koala bear their limbs around so they can curl around it. And then supine, we want to make sure that the parents understand that this is the safest and most important for them to understand before the babies go home, that that back is best, and babies should be in their crib on their back with nothing else in the crib but the swaddle prior to going home. So it's important for us to reinforce that before a baby does go home. These are some of the tools that we might use to help us with positioning. The snuggle up on the right, they come in different sizes, and that really helps create boundaries in a nest. Freddy the Frog can help kind of prop up the CPAP tubing, or it's kind of filled with, it's like a bean bag, so we can provide some nice deep pressure on the baby's bottom or their legs if need be. Here's some pictures of babies nicely positioned and prone. Same thing, providing a trunk roll so they can sort of curl their limbs around it and kind of think about a flexion pattern as much as we can. Side lying, what I mentioned, same thing, trunk roll on either side, allowing their arms to be nicely tucked to kind of close to their face. And then supine, this is sort of supine prior to this back is best safety, where it's just a swaddle. But the one on the left is not quite so ideal. The baby's limbs are still sort of outstretched a bit. Ideally, they'd be a little bit better tucked in. But the one on the right is really nicely positioned and on their back. And that one is a good example. And then for follow-up care. So this is important for us for early intervention. So that's generally what the referral we make when the babies leave the NICU, so that we make sure they don't sort of just get lost in the mix, that they're getting followed up with early intervention program on the outside once they get home. And that can be with developmental specialists, PT, OT, speech. And then some of the things that we might recommend, but we don't necessarily make the referral, it needs to come from the doctor, is the head shape clinic, which might result in requiring a helmet or something down the line, and then neuro follow-up at Boston Children's Hospital, which a lot of our babies might require. So that is what I've got. That was a lot of information. I hope you guys enjoyed it, but I hope I didn't talk too fast for you, and I'll open up for some questions.
Thank you so much, Sam, for that great presentation about OT in the NICU. We have a few questions that we've been getting from our viewers. We've gotten several questions about if you have any advice about getting started in the NICU, if you ever have fieldwork students, or any other steps you could recommend for students or OT practitioners to get started in the NICU.
Sure. So it is difficult. I know everyone is so interested in the NICU, and even just to sort of have a shadow experience, it can be really hard. It's such sort of an overprotected area of a hospital for good reason. But so unfortunately in our setting, we don't generally have students in the NICU because we're not there full time. So we really can't provide a fieldwork experience where the student is getting a full 12-week experience in the NICU. Generally, most of our students that come to St. Elizabeth's do have interest in NICU, so we try to bring them up there for at least a shadow experience at some point. But what I would recommend is that I think other hospitals who have larger NICUs, who have more of a therapy presence in them, might have a more option for student presence. But what I would recommend is there's some great courses that you can keep an eye out for. They're professional courses, but a lot of them are entry-level NICU courses. And if you can find one in the area that you live that you can take and just sort of educate yourself on the NICU setting, and then you can make connections and sort of network there, and ideally kind of work your way into finding something that might be available for you to even shadow or observe or get some more information. And I would just say kind of keep your ears open and take any opportunity you can to get involved in the NICU any way you can.
Great, thank you. Our next question is about the interprofessional team. If you ever work with PT or SLPs in the NICU, and what you see as OT's unique contribution in comparison to these other professions.
So in our NICU, we actually only have OT coverage, which is an interesting sort of approach in a level 3 NICU. I think it's very different in larger NICUs. Obviously, they probably have more than one OT as well as more than one speech and physical therapist. Ours is relatively small. We only have a max of 18 beds, and it's generally not nearly that full. So because of that, we're sort of the OT, PT, and speech. In terms of the speech, I do feel like we can do a kind of a basic feeding evaluation, but generally when there needs to be a more thorough feeding assessment, oftentimes babies will transfer out to another hospital, even just for the day, to get a more specific swallow study. A lot of times it's like a modified barium swallow where they can really see what's happening. And then in terms of the physical therapy, we act as the PT and the OT in our NICU, and we sort of address all of the needs as we can. But we have talked to some of the hospitals we are affiliated with, MGH Brigham, and talking about sort of what their roles are there and how they differ and how we can sort of incorporate more into our NICU. So hopefully that's more to come in the future.
Awesome, thank you. Our next question is about typical plan of care for infants with feeding difficulties, as well as if you ever see cultural differences, specifically regarding breastfeeding, or parents who are anxious or nervous to hold their new baby.
Yes, so in terms of feeding, sort of our role is very like the oral motor piece. So are we seeing a difficulty with a latch, or more so like the seal on a bottle nipple? Because there are lactation consultants, so they sort of work more with the breastfeeding piece, and we work more with the bottle feeding. So is there any trouble with the baby's coordination with bottle feeding? Can we assist with any type of oral motor exercises, any positional changes? So a lot of times babies are fed in sort of this semi-upright, semi-reclined position, and a lot of times even just putting them in side lying can help more of a natural breastfeeding position. So just making recommendations for holding and exercises that we can do to sort of strengthen their oral motor control and allow for more success in the bottle feeding. Also, any type of pacing we can provide. Paced bottle feeding is a great technique to use with any baby, especially if they're going between breast and bottle, but also specifically pacing the baby if they're sort of a gulper and they drink too much too quick, or do they need any support? Sometimes they just need some support under the chin, just because they're so they fatigue so quickly. They're just small, and it's difficult for them to get through an entire bottle without some extra support. So implementing that the best we can. I definitely do see some changes culturally with the breastfeeding. I'm not super involved with the breastfeeding because, like I said, we do have the lactation consultant. But even, for example, today we had a mom, and I think she was just really uncomfortable breastfeeding in the NICU with so many people around. So of course we provide as much privacy as possible, but they are open pods. So a curtain is really all that kind of separates. And she did express that she is interested in breastfeeding, but while the baby's here in the hospital, she much prefers to pump. So trying to facilitate that the best we can and encourage a more comfortable environment as possible. And that ideally, hopefully encourage breastfeeding the best we can. A lot of parents are very nervous both to breastfeed, but also to hold their tiny little babies. They can be really anxious. Dads tend to be a little more nervous than moms. So we really, as OTs, try to encourage that it really is important for the dads to be holding these babies just as much as it is the moms. So encouraging dads that might be a little more nervous that it's okay, and explaining sort of all of the things that they're seeing around the pod, all the tubes and the lines and what they're used for, so they have a better understanding of what's going on, and educating them on the importance of skin-to-skin care and even just simple holding when it's appropriate.
Great, thank you. And we have time for one last question, which is, what are some unique challenges working at a NICU?
Sure. So I think here, for me specifically, one of the major challenges is just the fact that I'm not up there all the time. So it is hard for me to sort of bop in and out from time to time, and there's not really, we don't have a regular schedule, so it can sort of be inconsistent, and that's a real challenge. And then because of that, partially, is getting our treatment plan sort of carried out. So we might find a baby has some type of little positional deformity in their foot, and we provide an exercise program and a positioning plan. We provide pictures, and we educate the nurses, but the nurses rotate just as quickly. So generally every 12 hours, and who knows how the transfer of information goes. So I might be up there on a Monday and provide this nice detailed plan. The nurse seems on board, everyone's on board with it. And then when I get back up there on Tuesday afternoon, the pictures that I've posted are gone, and the baby's positioned completely differently than what I recommended. And so it really is hard to sort of get our plans carried over where we don't have a constant presence. So I'd say that's one of our biggest challenges.
Great. Well, thank you all so much for joining us today. And thank you again to Karen and Sam for your presentations. We hope to see you again on March 27th for our next webinar on sensory enhanced yoga.